Good evening. This is RX Channel 10 with news anchors Mike and Tina. Tonight, our topic is hypothyroidism, and we have our reporters on the scene.
Hypothyroidism is a common disorder of the endocrine system in which the thyroid gland does not produce enough thyroid hormone. The National Health and Nutrition Examination Survey reported 3.7% of the U.S. population with hypothyroidism. It occurs more in women than men, especially for those in small body size at birth and low BMI during childhood, and the prevalence also increases with age. When testing thyroid level, we should only do it for patient at risk who is experiencing signs and symptoms. This includes family history, personal history, and autoimmune diseases such as SLE, celiac disease, type 1 diabetes, and psoriasis, and others. There are also some infamous drugs that can affect thyroid levels, most commonly glucocorticoids, short terms, amphetamines, amiodarone, and lithium. Other risk factors for thyroid disease include women over 50 years of age and a woman postpartum, or a history of neck irradiation. Hyperthyroidism and hypothyroidism are different, but have some similar signs and symptoms including hair loss and goiter, which is an enlarged thyroid gland located in the neck. Hypothyroidism can present as depression, constipation, dry skin, cold intolerance, weight gain, and lethargy, whereas hyperthyroidism will have signs of weight loss, tachycardia or AFib, menstrual irregularities, hypertension with widened pulse pressure, and heat intolerance. So Mike, how is thyroid regulated and how do we treat hypothyroidism?
Well, the hypothalamus stimulates the pituitary gland by secreting TRH, thyrotropin releasing hormone, which in turn promotes the release of TSH, thyroid stimulating hormone, from the pituitary gland. TSH travels from the pituitary gland in the CNS to the thyroid gland, where T4 and T3 will then be produced and secreted in the bloodstream. T4 is also converted peripherally to T3 in the tissues, and both T4 and T3 have negative feedback on the pituitary gland in the hypothalamus. When treating hypothyroidism, our goals are to normalize the thyroid hormone levels, provide symptomatic relief, and prevent neurologic deficits. We have two general options of drug classes, synthetic and natural thyroid. Generic levothyroxine, or brand name Synthroid, whose name suggests, is synthetic T4. The advantage to using this is that it has more predictable bioavailability and pharmacokinetics. The half-life is 1 week, so the steady state is achieved in 6 weeks. You would want to monitor TSH and free T4 every 6 weeks until the patient is euthyroid. Liothyronine, synthetic T3, is pretty much reserved for diagnostic testing when the T4 levels are low despite normal TSH and in severe acute hypothyroidism. Natural thyroid hormone is Armour thyroid, which is desiccated thyroid derived from bovine or porcine glands. For some patients, this is the only thing that works. For extreme cases of long-standing or untreated hypothyroidism, the condition can progress to mixed edema coma. This is highly fatal, and the patient will present with low sodium and glucose, decreased consciousness, coma, seizures, severe hypothermia, and delayed deep tendon reflexes. It can be precipitated by things that impair respiration, cold weather, and physiological stressors like CHF or DKA. The elderly are most prone to mixed edema coma. You would treat this by giving high-dose T4 or both T4 and T3. Next, we have Brittany, a P3 pharmacy student at URI who has hypothyroidism.
Hi Brittany, it's so good to have you here.
Great to be here, Tina.
We asked you here today to talk about your hypothyroidism, so we're going to ask you a few questions if you don't mind.
Go ahead.
So when were you diagnosed with hypothyroidism?
I was diagnosed when I was about 15, so junior year-ish of high school, with Hashimoto's hypothyroidism. So that essentially means that I have autoimmune hypothyroidism, so my body developed antibodies against my thyroid, thus resulting in low T4, T3 levels. So my mother has a history of Hashimoto's as well. And I had developed symptoms of hypothyroidism, including dry skin, some hair loss, mainly fatigue, energy issues. So they went ahead and screened me for Hashimoto's, and here I am.
So, what would you say is the most difficult part of coping with hypothyroidism?
Well, when I was first diagnosed, and especially before I was diagnosed, the lower energy levels were definitely a huge problem, especially being in school at the time, having to wake up early, and then not having energy throughout the day was very troublesome. So it's a lot better now that I'm on medication for it and the energy levels are higher.
That's great. Then, how has hypothyroidism affected you and your family's life?
Well, now that we're all being treated for it, it doesn't so much affect our day-to-day lives, but especially at the first diagnosis and before we had medication, mainly, again, the energy levels were a problem. For example, my mom always drank coffee to get her energy levels up because she thought she was just tired from not sleeping. So now she drinks upwards of 3 to 4 cups of coffee a day,
That's actually a lot.
which is a lot, yes.
That is a lot.
So I guess that's the only real big effect, I guess. Now that we're on medications, it's a lot less affecting to our daily lives.
That's good. Okay, then what has been your experience with the health system in the management of your condition?
So at the very beginning, when we were first being diagnosed, my pediatrician didn't so much know exactly what was going on, and especially in the school system, for example, my PE teacher in particular thought I was just being lazy and didn't have enough energy levels, wasn't sleeping enough, something like that, something I was doing wrong. But finally, we got a referral to an endocrinologist who is great. And she just immediately knew what was going on, got all the necessary tests, diagnosed us, and got us the necessary treatment. So in terms of the actual treatment, they started us off on a certain med and switched through a couple different meds before we got to the right treatment for us that actually worked. In terms of screening, we have to get blood tests every 6 months to check TSH namely, but also T3, T4 if necessary. And in my case, I actually had active goiter, like upon palpation they would feel enlarged thyroid. So for that, I had to go get ultrasounds to monitor its growth and development if it was getting too large or anything. So it's actually kind of a funny story because whenever I would go to the ultrasound wing to get my goiter ultrasounded, there were always, for some reason, a bunch of elderly people just hanging out in the ultrasound wing, looking at this 15-year-old girl coming in the ultrasound wing, just like, I see how it is. And I'm like, what? You wanna see my goiter? Yeah. So I guess that's another interesting thing that you have to deal with when you have goiter, going to get the ultrasounds. But other than that, once we got the right medication, the goiter actually went down and it's not enlarged anymore. So looks like we found the right treatment.
That's great. So as a pharmacy student, what are some changes do you think we could make when we're treating our patients like with hypothyroidism?
Well, one thing of note, I know we learned in class that specifically armored thyroid is a natural product and not as well regulated as synthetic thyroid medications. But armored thyroid ended up being the medication that actually worked the best for both me and my mom. Yes, it's very interesting because we were told to kind of not trust it as much being a natural product. But for some patients, evidently, it is the only thing that works. So that's definitely something to consider. Maybe try to be more open-minded about potential options that could work for some patients, but maybe not all. So I think ideally, probably, you would go with the usual sequence, levothyroxine synthroid, which I did, I tried. And then, so one last thing that I wanted to mention also, which is sort of just a concern I have, my sister and my aunt, so my mother's sister, also exhibit all of the characteristic symptoms of hypothyroidism, at least, maybe not Hashimoto's, but for example, the low energy levels, dry skin, hair loss, the whole kit and caboodle. But they went to the doctors, obviously, because we told them, hey, it's probably hypothyroidism. And they tested their TSH, T3, T4 levels, and all came back normal. Now, we learned in class, right, that that can be true, meaning that they have normal levels of all of those biochemical markers in their system, but their cells are actually resistant to the thyroid hormone itself, which makes sense. Just like type 1 and type 2 diabetes, the cells can be resistant to the thyroid hormone. But when we went to the doctor and tried to get a diagnosis of that type of hypothyroidism, they just said that they didn't have it. Like, no, your levels are all normal, so you don't have hypothyroidism at all. So they didn't get any treatment, where normally, as we know, you're supposed to get a higher dosed level of levothyroxine, Synthroid, whatever. So that's sort of just a question that I have up in the air. What happened there? Why were they not diagnosed with that? And we've even seen multiple prescribers about it, and they all kind of say, no, your levels are normal, you don't have anything, we're not going to prescribe you anything. So that's my last concern, I would say.
That's
a question that's up in the air.
Actually.
Yes, it is.
Okay, thank you so much for being here today.
You're welcome. Had a great time.
Many people have hypothyroidism, and Brittany has elucidated her experience with Hashimoto's, an autoimmune form of the condition. As she explained, untreated hypothyroidism can throw some obstacles into your life. But once it's managed by medication, that medication will increase the quality of life. This has been Channel 10 News on hypothyroidism, and this is Mike and Tina at night. God bless America.